remind people that the speakers in the ceiling are sensitive and will pick up background noise. So do try to keep this to a minimum. We're not expecting a fire drill this morning. I think that means we are not having a fire drill this morning. So if the alarm does sound, please do follow the officers out of the building in a calm manner and gather in the cathedral grounds. We tried to seat board members around the tables. If there are any gaps, those of you sitting round the back are very welcome to come and fill them. So please do. And if you want to come and speak and there isn't other space, there is a space there allocated down here for anyone who wants to come and sit there and speak. If you get the opportunity to do that, please do, because it helps in terms of the audio for people who are watching online. Some members are joining us via Zoom today.
So we'll go through, if we can, please, it'll always help me. Could the board members, not the non-board members, could the board members please just introduce yourselves? It'll also help Judy, for whom this is only your second meeting. Your first. So John Spence, Chair.
Jyoti Attry, Director of Public Health.
Going left to right. Somebody go first.
Dan Doherty, Alliance Director from Mid-Essex.
A bit slow for you, Dan.
Sorry.
England will never beat New Zealand. Yes.
Gina Placey, North East Essex Alliance Political Representative.
Laura Taylor-Green, Executive Director, North East Essex Alliance.
Morning all, Greg Middleton, representing Roger Hurst, Police, Fire and Crime Commissioner for Essex.
Well, I think that's a win-win for us, isn't it?
Morning, Councillor Peter Davey. I'm the Chairman of the Essex Association of Local Councils, looking after all the town and parish council sector in Essex.
See you, Peter.
Good morning, everybody. Will Pope, I'm Chair of Suffolk and North East Essex Integrated Care Board.
Will.
Good morning, everyone. Pete Devlin, Director of North East Essex Alliance Adult Social Care Services, representing Nick Presmeg, Executive Director of Adult Social Care this morning.
Thank you.
Ian Tompkins. Today I am Tony Coles, West Essex Health and Care Officer.
Morning, Sam Glover, Health Watch Essex.
Hi Sam, how are you?
I'm very well, how are you?
Excellent.
Excellent.
Very good annual report. Haven't finished it yet. Right.
Tom Walker, Executive Director of Essex County Council.
Ian Davidson, Chief Executive from Tendring District Council and Vice Chair of the Board.
You hope.
Until the election, they don't get changed.
There's a kiss of death.
What previously?
So, Ian, are you the other person? Oh, sorry, who's joining us online? There may be more people online.
We have Deborah Stewart Angus online, Mike Thorne, Paul Burstone, Susanna Howard, and that's it. Yeah, that's all I've got.
Good morning, all of you online. If we have any trouble spotting you wanting to speak, please, I'll do whatever you need to make us speak. Jump out of the screen or something. So, so that's fine. Right, we have. Where am I going next? We have apologies, please.
Yep, I can do that, Chairman. So we have apologies from Nick Presmeg, Peter Devlin substituting, Simon Williams, Rebecca Morton, and Anastasia Simpson substituting, Rebecca Jarvis, Alison Wilson, Councillor Graham Butland, Sanjeev Alawalia, Dr. Ian Perry, Dr. Jane Halpin, Frida Batty, Gavin Jones, Claire Kershaw, Lance McCarthy, and Roger Hurst.
Okay, I'm fair to say, Tom Walker, that you're representing Gavin Jones, aren't you? So you're his named substitute now.
I'm sorry, and Tracy Dowling as well. And
Tracy Dowling has left, hasn't she?
She's in essence on annual leave towards the bit she won't.
So effectively, so I think I just want to minute our thanks for her contribution while she was here. She was an invaluable aid in sorting out some issues. You should have apologies from Lee Scott. There seems to be a query. He is the new second councillor on the Health and Wellbeing Board from Essex, and there seems to be an issue as to whether he had papers or not, which I'll sort out later. I need to do that. No, what's it having to do with the election now, I think. So we are asked to elect a vice chairman for the civic year 24-25. I have received the nomination of Ian Davidson. Does anybody else wish to propose another name? Are we happy to accept Ian with a claim?
Yeah. I'll propose,
Yes.
Chair.
All right, Ian. I knew that would absolutely make you. Minutes of the last meeting have been circulated. Are you content that they are a fair and accurate record?
Yeah.
Okay, they're in very enthusiastic moods today, so a bit more choral acceptances will be gratefully received. Are there many matters arising from the action log that we picked up at this meeting?
No, none from the action log. There's a few, there's a lot of details in there about what's happening going forward, as it says there, but nothing to point up.
Okay. And anyone else on the board wants to raise anything? So on your agenda, it now says public questions. If you members are okay, I'd just like to take one item which you could almost call a matter arising before we go to public questions, and that is the final endorsement of the Better Care Fund Plan 24-25, which has already been submitted but requires our formal sign off. Is that okay with everybody to sign off?
Yes.
Not much you can do if you want to say no, so fine, right. And the reason I want to do that is I've had notice of a public question which is about the ambulance service, so it seemed better to me that we have the public question immediately before Kate gives us the ambulance or speaks to the ambulance service report. So Councillor Mark Durham, are you coming forward?
Thank you, Chairman. In the context of the report from East of England Ambulance Service, I would like to ask the board's views, and ideally those of the ambulance service itself, on the following experience that I've personally had in the recent weeks. An elderly lady, 88 years old in actual fact, had an ambulance called for her at 11 a.m. because the facility she was in feared there was a threat of sepsis. The ambulance arrived 20 hours later at 0600 the next morning. In addition, the same lady, when she was subsequently told at Broomfield that she was to be discharged from hospital after 15 weeks, I might add, from hospital at 9 a.m. By 7 p.m. that evening, the crew had not even been allocated. And I'm afraid the list of failures with the ambulance service and my personal experience, and actually that I've received as a member, the failures go on and on. In light of this, I would welcome a response from the service itself and ask the board's view how the health and care system can come together to stop this sort of appalling experience to happen again to myself or to any other resident of this county. Thank you, Chair.
Thank you, Councillor Durham. It is not for us to discuss the operational case in question. I'm sure each of you wish to pick up with Mark outside the meeting, you can do so. The issue really is we want to hear, Kate, how the service continues to seek to address issues like this. I think on the second piece of Councillor Durham's question, it's quite silent about handover to discharge, actually, and how that's working. So I'd be interested in that. And really how we can help you, Kate, to keep pushing on with improvements. So over to Kate. Kate, sorry? Morton, sorry, I knew I'd get that in a minute.
I just go with Kate.
The ambulance service report.
Hi, I'm Kate Morton. I'm the Deputy CEO of the ambulance service, and thank you to the councillor for his question, and absolutely taken into account we can't talk about the operational matters, but very happy to pick up your case and talk through it in more detail. I think it's important to say as well that for your system we don't provide the discharge transportation, that's done by a different provider, but absolutely that front of house piece. The report, which is quite lengthy, and apologies for that you've got, that was circulated with the papers, gives a rundown, I think, of all of the key areas that we've been working on, and when I was here last time, I think we spoke about each of them as well. And I think it's fair to say we've made progress in all of them. I think as the example just given demonstrates, it's still a difficult context in which we are operating. So we have improved our response times, but they are still, as detailed in the report, but they're still not where they need to be. I think it's really important to say that up front. So we've increased our staffing numbers for our call handlers in our emergency ops centres considerably, and going through the training and the process for how we skill those individuals up and support them has been completely changed in terms of making sure that we've got a much more robust way of keeping the staff when we recruit them. And then from a frontline perspective, we've increased our footprint by 300 staff across the region. But I think, as with everybody, I'm sure, who's trying to recruit clinicians at the moment, it takes time to train these individuals up and get them workforce effective. So although we've done great work in terms of attracting people into the organisation, recruiting them, taking them through the process, actually feeling the full benefit of those individuals and their impact on performance is still going to be a good 6 to 12 months down the line. So we were starting to feel it, and I think we've internally enabled our teams to understand that there's a real commitment to getting our staffing footprint correct, but we also need to support the individuals, many of them who are young people coming into the service, to be skilled up and trained and supported in the right way as well. We also, at the same time as doing that, and this is part of the new, I suppose, new care model that we're bringing these additional workforce into, have been working with yourselves and all of the systems around how do we manage what appears on the 999 stack in the most appropriate way. We still have a lot of activity that dials 999 because they aren't able to access alternative services. And we've got I personally feel a real responsibility for making sure we help those individuals navigate to the right services, but also that they understand, I think, from professionals that look after them on a Monday to Friday, often 7 days a week in their local area, are also part of what happens to them when they have an urgent emergency incident as well. So I think we spoke last time we were here about the unscheduled care hubs that we've set up, which have been a brilliant success. We've, especially in your footprint, you've got 3 that sit within the Essex footprint: Herts and West Essex, Mid and South Essex, and Suffolk and North East. And I think the commitment and the energy over the last 18 months now that has gone into building the hubs and building a multidisciplinary team that supports the people that have called into 999, that we share the calls because they're lower acuity and actually they need a different, more joined up offer. Which can be accessing the acute still, the hospital still, but in a more planned way. And I think being able to understand demand at a geographical level better has also been one of the I'd say side effects, that's the wrong terminology, has been one of the learnings that have come out of the unscheduled care hubs. We've also worked with our systems to introduce call before you convey, which sounds a bit jargony, but that is basically working with the systems to, when we have a crew on scene, or when we have a call that has come in that doesn't needs urgent help but doesn't necessarily need an ambulance, it's working with the system to wrap around that individual for a longer period of time. Cambridge and Peterborough is probably our most evolved version of that, followed by Norfolk and Waveney and yourselves in Mid and South Essex. But for the Cambridge and Peterborough example, they hold the patient for 4 days, take them through additional appointments, any additional diagnostics, prescriptions, etc., and then discharge them back into their primary care or community routine process they may have already been in, or instigate that when they haven't necessarily already been on the radar of their local providers. So it's a big piece of work, and it's quite a significant organisational development piece, because it's getting our teams to truly work at system level. So although we've been sort of on the journey now for just over a year, it's still there's still a lot to do. But I think the thing that strikes me, and I think it's particularly clear with the leadership that you've got across all 3 of your ICBs, there's real passion behind actually how do we wrap the services around the patient. rather than actually looking at someone ringing 999 who doesn't need an ambulance as having dialed the wrong number. I think that's a really important sort of step forward that we've done with system partners, but also I think that is now evolving, and there'll be the ongoing issue around how that's funded going forward. But when you look at the kind of direction of travel around integrated systems and how we need to evolve our services, it absolutely is in keeping with that. The other piece I just wanted to make sure I'd mentioned, because I think from an Essex perspective, and thank you to Rick, the Fire Chief for Essex, he's been amazing. We've done a fantastic piece of work on our Blue Light collaboration, introducing a new role of community wellbeing officers, which are a dedicated recruited resource in the fire service, which is again picking up our lower acuity calls, being dispatched from our 999 call centre with a focus on falls, but also more broadly being able just to make sure we can get somebody to individuals that need help as soon as possible. And they've had quite a lot of press coverage. I don't know if you've seen any of it, but I think it's been something that's really landed well with the patients that they've supported, and they've been able to also do the preventative piece, the house checks, the kind of safety look that's part of their core role as the fire service, as part of the response as well. So I think it's a good example of where we've looked at what is the capacity in a system that could support the population, not just about a blue light or from an ambulance perspective, but actually where have we got individuals who are in need, and who is the person that we can probably get to them the soonest to help them in that situation. But as the gentleman's example shows, that's still a work in progress, and there's a lot more to be done. And the last point of note is really the handover delays. We're in a better place than we have been, but it fluctuates. And I think because we are a regional provider, if we have one of our parts of our geography that is experiencing particularly difficult handover delays, that can often have an impact on the fleet and how we can dispatch the fleet in other bits of the system. We have definitely seen periods of improvement, but routinely in order for us to make the improvements we need to make around category 2, we really need that to be under 1,500 hours per month as a region, and we're routinely a lot higher than that. And I think that's part of the conversations that we're having with our system colleagues and our acute colleagues on a routine basis. And it's something that I think we've had an enormous amount of enthusiasm to support with. But the difference probably now to when we were having this conversation a year ago is that when we are in that period where we have high handover delays and a reduced resource available to dispatch, we now have other tools in our toolkit with the unscheduled care hubs, with our community wellbeing officers, with just that ability to have a different type of conversations based on the relationships we've built. And just one very last point, I mustn't miss them out. We also have ambulance staff, local area coordinators that sit within your control centres as locally as well. And I think they've helped with those conversations around handover delays, just to be able to understand what logically would improve flow, increase flow. And if that's had to result in us helping with discharges where we don't necessarily hold the contract, or just understanding what we can do as the ambulance service to help reduce the handover delays. That's been part of the conversation and part of something we're open to keep as an ongoing conversation as well. Happy to take any questions.
Thank you, Kate. That was very thorough. Thank you. Can I have hands, please, showing for comments and questions, and I'll take a few at a time, assuming there are plenty.
Ian Davidson, Peter Davey.
Anybody on your screen?
Screen.
Right, so we come first to Ian Davidson, then to Peter Davey.
And then Jyoti.
And then Jyoti. Thank you. Ian.
Hello, thank you for that. Really interesting. My question is sort of more around how to perhaps alleviate some of that pressure. So some of the longest calls, the longest distance you have in the region is from hospital to an outlying post is from Colchester to Clacton. So the highest number of rates of calls you have is from Colchester to Clacton, and the older population is Western Europe, and the area is Clacton. So consequently, there's a concentration of, as we know, there's sort of some of the pressure for you, and therefore then the journey times for you is that Colchester to Clacton journey. We also have a number of issues around, obviously, for people with falls and about lifting. So it may not be they actually need to go in if they're lifted quickly enough. And I was wondering, there were conversations previously about putting something in place whereby rather than it needing that ambulance run, but having a lifting service, which would reduce that call on your ambulances in order to free them up and also not spending that much time in those long journeys and then the waiting times at Colchester Hospital. And I was also noting the other thing on your report was around the changing culture work, because obviously on the previous report there was some quite significant issues. And my question on that is where do you feel you are in that journey?
Okay, so I'll start with the first one. Okay, Chair. I do remember the conversation that we had last time, and I think what we've done since that was we've got an amazing army of community first responders who have an awful lot of equipment that very often they've fundraised themselves to purchase to help with falls and to lift, as you're saying, people up off the floor before they are in a position where they then have to be conveyed. Being really open and honest, we are still not as good as we need to be at dispatching those individuals. So the workaround that we've been using in that particular patch from the SNE hub has been it's been the only hub we've been able to dispatch our community first responders from, because they are, again, back to my earlier comment, they are a resource that's geographically located, and they are your community who are wanting to volunteer and wanting to give back to their community. So if they sit on our books but we are not using them in the way that we do need to use them, that's a really important point. And that's the conversation we've had with SNE, has been actually how do we then align that resource to yourselves, particularly for falls, so that we can start to mobilise them quicker and just utilise the resource. So we've started that. The pilots worked well in that sense, where we've actually even Tom, who you've got as your incoming ICB CEO, has been dispatched from the SNE hub as well under his CFR banner. But there's still a lot more to do, so that is kind of the priority for this year. And also just on the activity point, ultimately we want to try to not convey those individuals to hospital, because obviously that very often can lead to a different experience for them. So I think the success of the Suffolk and North East Essex, well, all of the hubs, but in dealing with those lower acuity calls from the geographical perspective, making sure that the people that end up going in are the community teams that are based locally, rather than the ambulances who then potentially need to convey. That's kind of been the drive behind this as a broader piece of work.
Kate, I'm just conscious of time. We've got several people wanted to ask questions. Could I ask questioners please to be concise, and if you can, Kate, try and keep the answers full but concise. And if need be, I will take a list of questions for you to come back to and write if I run out of time. Peter Davey, then Jyoti, then Ian Tompkins.
Thank you, Kate, for your comprehensive report. Very quickly, your response model. Okay, we had personal experience of it, and just to feed back to you that we expected a paramedic and ended up with an ambulance with two paramedics for a breathing problem. They did an inhibitor to alleviate that, and then they actually sat there for 45 minutes waiting for a doctor to bring them back so that they could be released. And that means that that ambulance was sitting outside for a good hour and a half, where it should have been in a prime emergency, and that was all done through 111. So you need feedback like this to make you understand that the model itself sometimes is broken, and I don't understand why that happened.
Very much in the same territory as Mark Durham. I'll take another one and let you come back, Kate. Jyoti.
Thank you. Could you share with the board how we compare to national rates for C1 and C2 response times, and how far we are from target? And I wondered whether you've done any work to look at the potential impact on, or the actual impact on mortality rates because of the delays, and also what your plan, when are you intending to reach target?
There's a good full one for you, Kate.
Thank you very much for that. We don't benchmark well on the national targets, absolutely. I think between us and London Ambulance, I think we jostle often for the bottom of the table. So it is a significant issue. on the mortality piece, that piece of work has been done before, and we've done it with our individual systems. I don't have the figures to hand, but I can, because I think that, especially if you're new in role, it might be worth sending you through what we've done previously as well, so that you can see it's particularly for your patch, because the mortality piece underpins a lot of our conversations around the handover delays as well, and where risk sits in the community, rather than it just always necessarily kind of sitting on the 999 stack. It often, or at the hospital front door, it often is the individual who's in their lounge who we can't get to. We've had a significant decrease in the amount of SIs that we've had since in the last 12 months. This last winter was much better than the winter before, but still not good enough, being really open and honest. But I'm happy to share figures and perhaps have a separate conversation with you, just give you a bit more background as well.
And when are you aiming to reach target?
Oh, Q3 of this year. So, but that is dependent on, I think the trajectory that we've submitted, I know, is dependent on the handover delays. That is such a significant, has such a significant impact on just the amount of rolling stock that we have on the road at any one time. But yeah, at the moment, that is the trajectory, and I can share that with you as well.
Ian, can I just take any other hands? Well, Ian Tompkins.
Yeah.
Hold on, Ian, I'm just seeing if there's any more hands.
No.
Okay, I'll come back. I'll come after that then. Ian?
Thanks, Chair. It was just really a quick offer. What, if anything, can we do in the ICSs to help with public education about the accessing to services? I know we already do quite a lot about the NHS generally, and in particular 111, but being on the ground in communities, particularly in areas where they're not necessarily used because of changing demography about how to access services, because they do it another way back from whichever country they've come from. It's just to put that offer out, and I'm sure I speak on behalf of the other ICSs in saying that.
Thank you very much. Very welcome.
I think, Kate, listening to this, the report was very encouraging. I think what comes out is there's further to go, which you'd obviously acknowledge. I'm just interested how you determine who's in the highest priority. So we're not discussing any individual case, but you might have expected a very elderly person with suspected sepsis would be in the top priority box, or maybe the top two priority boxes. So I'm just not clear how that works. And you've heard discharge is the bit we get a lot of noise about, or we hear a lot of noise about people's left sitting in hospital for many hours. So there's one piece about how quickly you can get the ambulances there. There's another piece about how we could improve communications between the ambulance service and the hospital and the resident. You know, if it's not going to be there for 12 hours, tell people it's not going to be there. So often communications can ease what's otherwise a major irritation.
Yeah, absolutely. I think from the discharge perspective, that isn't necessarily always asked, but I think as a regional provider, part of the conversation we've been having with the ICBs is all of us have, and a stakeholder in the system at the same time, all of us have got responsibility for keeping flow, because if we're not discharging patients, we're also then causing a problem at the front door. I've forgotten the first bit of your question. What was the first bit of your question?
Sorry?
What was the first part of your question?
The first part was how you do how are priority ones and twos determined?
Okay.
I was talking about an old lady with suspected sepsis. I'd have thought one or two.
I would also, so that's why I'd probably like to have that conversation in a bit more detail. It's all calls are triaged by and they are all follow an algorithm as well. So if they are category 1 call, they are automatically dispatched, and that also works through via 111. And category 2 has got an automatic dispatch from 111 as well. So I think I need a bit more detail on that specific case, but absolutely, it's either an automatic dispatch or it's a clinical triage. So, and it's a nationally agreed process. It's not something that we've agreed locally, and it's audited very heavily as well. So, yeah, there's definitely learning there.
Okay, but I think I've got no more hands outstanding. Thank you very much. It's an encouraging report. We know that you're aiming to get up to targets in Q3 of this financial year. So it'd be great if we could come back. It's not for us to be a host here, we're just interested in how it works. And whether you want to make it July next year or whether you want to come a bit earlier, please liaise with the team.
Thank you.
I'd encourage you to think about how we can work. 2 or 3 people have raised the question, how can we work together? I don't know what appetite there is in the ambulance service for further work around prevention of ambulance call-outs, which we tried to do with CareTech. Whether you would wish through our caring communities work to look at trying to encourage the growth in first responder and other community voluntary teams who can help you. And I would really encourage you to not wait for another year, but to come back and talk with us about how can we work together collectively to ensure that the ambulance service is not just meeting national benchmarks, but beating them. Okay?
Yeah,
If I can
absolutely.
invite you to think about that and come back with an agenda item.
Yeah, I'm happy to. Thank you for the offer.
No, thank you, Kate. You're very welcome to stay or go as you see best use of your time. Now, Will, what's next?
It's the evaluation of the wellbeing hubs in primary school.
So this is the initiative that was begun in tendering. Who's speaking to this one?
We have Tracy, Caffel and
Basin, Carla, you're very welcome. The report has been circulated. I'll obviously, can you just please speak briefly to the report to leave time in our agenda for discussion?
Thank you very much for having us. Very briefly, the Wellbeing Hubs are activities that are going on in primary schools in Tendring and Colchester. The Wellbeing Hubs themselves are 5 to 6 structured sessions in which young pupils can get together and talk about their issues. They have some lessons that they learn. They can do activities. And these are really all around developing resilience skills, empowering the children to develop their self-esteem, learning how to express and recognize their emotions. And so these hubs happened in 2021, 22, and I was asked to do some evaluation of them. So we looked at several different well-being measures, including resilience, well-being, self-esteem, anxiety, happiness. We looked at the pupils who had completed surveys pre-hub and post-hub and looked at how things might have changed. We also did some whole school surveys. I'm not really going to touch on that because not a lot had changed there. But within the pupils that attended the hubs, the things that we noticed the most were that there were increases in resilience, which is very good, and also increases in well-being. So those levels increased. One of the surprising findings was that self-esteem actually decreased, and I can talk a little bit about why we think that is. If you have questions about that. We also saw that levels of anxiety and happiness increased. So they were less anxious, more happy after they attended the hubs, and their feelings about their school. So whether they enjoyed learning at their school, whether they felt their school was encouraging to them, those feelings actually increased after the hub, which is also a good thing. And then as for attending the sessions themselves, most of the pupils found that the sessions were quite helpful for them. And the things that they really liked were the breathing and relaxation techniques, the things that were quite hands-on. So building things, doing arts and crafts that help them tactilely release their stress or reduce their anxiety. And other things like having a trusted adult to talk to, being able to listen to other pupils who had similar problems and realizing that they were not the only ones that were feeling the way that they were feeling. Having these small settings where they could open up and talk to people, and also putting what they learned into practice. So some of them did mention that they'd go home and share the lessons with their parents or their family, and they were also using the activities or the techniques that they learned in these hubs to help reduce their stress and anxiety outside of these sessions. Again, as I said, the whole school surveys, wasn't really much difference between 2021 and 2023. We did ask parents some questions about why their children were referred to the hubs, how the behaviors of their children might have changed. And most of the reasons around referral were around poor confidence and self-esteem, their children being stressed and anxious, social isolation, and a lot of these things they did say improved after the hub. So they saw improvement in communication, their children had more confidence, they had higher self-esteem, they were less stressed and anxious. So not only were the children expressing these things about themselves, but the parents were also seeing it as well.
Okay.
And then finally, we asked the school staff about their experiences. And again, they're very, very positive about the hubs, about the differences that they were seeing in the pupils, very similar to what the parents had said. There were some things that they pointed out as being barriers. So some of the reasons why the pupils did not attend were around parents not understanding the importance or not wanting their children to kind of be stigmatized by attending these hubs, clashes with other events happening within schools. These hubs were taking place during school times and not outside of school time. So there's some clashes there. And then also within the pupils, some of them refusing to attend, being shy, and also having some transportation concerns as these were taking place. And so that's I think the highlights of the hubs overall. Again, they were quite positive and people seem to think that they were very useful and are looking for ways to keep them.
So in your expert view, we can chart improvement here. Would you expect that improvement gap to get greater as time goes by if these are maintained? Or do you think it's now reached a level of maturity, if you like? And B, is the quantum of improvement significant enough to make a case in a world of competing for resource that these should be rolled out more widely?
Chair, may I answer? Thank you very much for your questions. Tracy Caffel, Director of School Improvement and co-founder with Rebecca Morton of the IME Wellbeing Hubs. It's our understanding in schools that we believe things, the improvement for children will continue and improve and increase. The reason we feel we had slightly smaller margins at the beginning was partly because we started it during COVID. We didn't let that stop us. And we have noticed that some children have repeated their experience through the hubs and sometimes have attended 2 or 3 times, and that made a difference to them. We've addressed some of the barriers, so sometimes they're before school and after school, so they don't impact on the school day or the teacher's workload. And the reason we feel that they are absolutely part of the future of mental health is firstly, we are being asked by schools in as far away as Great Hawksley and Tiptree if they can be joining into the project. The champions that lead these hubs in schools have already given their own time to co-write manual 2, so they've given of their own time to do that. And my recent research following a meeting at Tendring District Council shows that 76% of schools involved in the hubs have reduced referrals to outside agencies, and 22% of the schools have reported that they have referred no child on to external agencies because of their initial early intervention mental health work in the hubs.
Very good answer, thank you. Hands round the room. I do have a non-board member here, Councillor Goodlowry, who's from the Scrutiny Committee, so if you wish to ask a question, Carla, that will be fine. Will, hands up?
Yeah, there was Councillor Guglielmi to begin with, and Ian Davidson, and then there's a few more as well. There's Sam Glover, Ian Tompkins, and Pete Devlin.
Right, so I'm going to sort of swing the order a bit to let new voices be heard. Carla, I'll let you go first. Sam, would you like to go second? Ian Tompkins third. I'll come back to the others.
Thank you, John. My name is Guglielmi. I'm the Vice Chairman of the People and Family Committee at County Council, and we conducted a task and finish group to look at services available to young people who have mental health issues. You were very kind to invite me at the January 2023 board meeting where I presented the funding of the Task and Finish group. And there were a few recommendations which the board agreed to look into it. First of all, it's excellent news what we've just heard. Something so simple and relatively low cost that has been rolled out in over 30 schools across Colchester and Tendring. That is a massive achievement, you know, because what it does, it stops issues becoming full-blown mental health problems. Anxiety, if tackled at the time, as we just heard, you know, it's kind of puts it to bed once and for all. It gives the child confidence. And so our report was very much funded on that. And we did ask if the three ICSs would look to roll it out across Essex because of its simplicity and because of its low cost. That was an action that, you know, I did ask if that could be taken away. One of the outstanding recommendations.
I'll ask you to come to your questions.
Yeah, has the SESs looked into rolling it out across Essex? That's my first question. The second question is to understand why there was so many people leaving the profession and what can be done to retain those highly skilled individuals into their positions, and has anything been done on that? Thank you, John.
Okay, thank you. I'll come back in a second. Sam, can I take you next?
Yep. So some fund are stolen there because that was one of the points I was going to ask. The second was, did you say children's self-esteem had gone down? And if so, do you have any understanding of why that may be?
Okay, thank you. And then I'm coming to Ian and I'm handing you back to do a collective response. Ian?
Yeah, I'm speaking on behalf of our Harlow Health and Education Partnership, and we have heard about this. And again, there's a couple of head teachers and a few of us from Harlow would very much like to come and see what you're doing there. I think also we should be conscious, we don't know yet. Of course, this year is the new intake in primary of so-called COVID babies. So it'd just be interesting to see, and timely, I think, to come and see you.
I am going to say, if it helps, I think, Jyoti, I need to ask you to liaise with the integrated care systems and with the education portfolio holder, Tom Walker, with your help, please, to have a discussion about, is this something that can compete for funding? Okay. I think the issue is not for me, Carlo, whether we can say to them, roll it out. We need to see if they agree there is a case for rolling it. Okay. But over to you.
I think I'm going to start backwards and remember as much as I can. With regards to self-esteem, I think that was one of the most important questions. We think originally those slides have gone down. We have actually been running hubs, and recent collection of data has shown that it has improved. That snippet of data was also during the COVID years, which we know has moved on, but we know still has its legacy. We also believe that while we were working with our Gordian
Okay, and thank you. I think we just note those comments, okay? Thank you, and the passion on this item of the room is very evident. So Tracy, can you just confine yourself to the one question, please?
Academic achievement and attendance. Attendance has gone up. And as a head teacher who started this hub at Great Bentley many years ago, and I chose wellbeing over academic achievement first and foremost, didn't forget the second because that's incredibly important. Our school moved from an RI judgment to an outstanding Ofsted, which we retained in 2022. I believe that's because we had the village that raised the child. We made it about the whole child first. Wellbeing was first and foremost. Academic achievement followed. Hugely proud of that team. I think we tick both those boxes. I think I'm done.
Tracy, if you'll thank you. That's a very rare achievement here to get applause. And if I might just say to you for a moment of humour, if I was an Ofsted inspector, I wouldn't dare give you anything else. But very well done to you and Carla. It's a very interesting item. We have taken an action, please. And we need to involve children's services as well, because if this reduces referrals into children's services, Jyoti. So I'm asking Jyoti to take the lead in ensuring that all appropriate parties come into a discussion, not to consider whether this has been a success, but to consider how it might be taken forward given other priorities. But very well done.
Thank you so
You're
much.
very welcome to stay. Okay? If you wish, if you need to go, we understand. Can I apologise to those of you joining us remotely? I understand the link was lost, but has now been restored. We don't know why, do we? So we'll hope for the best, okay? We now come to the Coastal Communities unit at University of Essex, and speaking is
Dr. Emily Murray.
Emily, how lovely to see you again. And could I suggest, given time pressures, I wouldn't talk more than in a minute to the paper, which you can assume is being read as quite technical. Really focus on purpose and how can we support, okay?
So Dr. Emily Murray, Director of the Centre for Coastal Communities at the University of Essex. And I've come to the board with three purposes, which I think the first one was just to introduce the centre to the board and to residents, because we're a new centre that just started in the autumn. And to talk about the vision of the objectives of the centre, I put this all in the PowerPoint slides, just to say this is a centre really to be for the community, not just an isolated academic ivory tower and exercise. So it's really important to us that we bring together our researchers at the university around coastal research, that we do that in partnership. And that is a big reason why I'm here, to say we don't know what the issues are important to the coastal communities unless you tell us what they are. And equally, you need to know what our expertise is and what we're good at. So that's what we're working on, going to be creating an e-brochure about our coastal expertise and putting that on the website. So over the next 6 to 12 months, I can send that to the board when it's ready, so that you can say, oh, well, we would like to do some research on the subject. You know exactly who to contact and what we do. That's just the first point. The second, I want to specifically say there's an opportunity to highlight. So Professor Gina Reinhardt in the Department of Government has just won an almost £3 million grant, 5-year grant from the UK Research Council to develop resilience within UK coastal cities and communities. And she wants to work with local stakeholders to design and test 12 different interventions that can be used to address the challenges that coastal communities face, which could include health and well-being of coastal residents. And I wanted to say, if you're interested in this area, she'd really like to work with you. It's just getting started. I think the first meeting of the team is in November. So I think it's really important that you get the feedback from this group, or who you think might be appropriate, to contact her and get into this community of feeding in what interventions should she be looking at and which local stakeholders she should be working with. I know she has some already identified within the grants, to be able to, get your voice in that project and use those resources from UKRI to build these toolkits, etc. So that's the second thing for me. And the third point is really I wanted to talk about my research a little bit as well. So I had put some questions in the PowerPoint, but I'll say them again. And basically, so I've done some research looking at young people in communities and their health, is using the Understanding Society data set to look at adolescents aged 10 to 15 years old, and then follow them up to 11 years later and look at their health and well-being outcomes. So things about self-rated health, mental functioning, psychological distress, disability prevalence, and physical functioning. So those different outcomes. And really the message that has come out of that research is to say, it's not all young people who live in all coastal communities. It's those who live in the most deprived, 20% of coastal communities, have much worse mental health functioning and psychological distress than their equivalent peers in equally deprived areas inland. So they're saying there's some kind of coastal mental health effect for young people. So equally deprived areas on the coast versus inland, worse mental health for young people. But this is Understanding Society data set. This is a national data set. So the numbers don't really allow to look at it at a local level. So I think I would like to be able to come to the board and say, oh, you know, this isn't an issue in this coastal community, but I think, and so I've been on a hunt for local level data about young people's mental health prevalence, which I cannot find at a publicly available data. I was coming here today to say, is this a pattern that you've seen within your ICB local data? Have you looked at this? You know, and if you haven't, is that available? You know, could we work in partnership to be able to look more at a granular local level to say, where is this a problem in Essex? And where might this be? So that's my call out to you to say in partnership. That's about it. And then on the policy implementation side, I read through the South End Essex and Zurich mental health strategy documents. And the strategy mentions implementation at locality and place, but it doesn't mention specific places. And I had wondered, are any of these places deprived coastal communities? Do any of those projects focus on young people in these coastal communities? So those are my.
Okay, thank you, Emily. I'm going to just suggest that for this item, while we are the Essex County Health and Wellbeing Board, we remember that our coastal communities are not just Harwich and Clacton and those places, they go right round Southend and Canby Island and on up to Tilbury. So these issues, and I think if I was to make an appeal, it is that you use the huge bodies of knowledge on this already. I really hope the Coastal Communities Unit will be able to take things forward into new areas. And if I may say to the board, I chaired the Deputy Prime Minister John Prescott's advisory panel on this in the late 2000s, about 2005 to 10. I was involved in the work on this with the South East Local Enterprise Partnership and other local enterprise partnerships. I was involved in the Church of England Commission on Coastal Communities and Deprivation. There are huge amounts of knowledge as to what the common factors are. And our previous Director of Public Health, Dr. Michael Gogarty, so that was 2 ago, was himself an expert on this. So I would just appeal to you, there's a lot of knowledge, and the great thing for me will be if the University of Essex can build on that and find new insight. Absolutely terrific. Questions or points? I don't think anybody in the room will say anything other than we recognise a problem in our coastal communities or as issues. But questions, hands up.
Yes, we got Becky Jarvis has joined, and Sam Glover and Chris Martin.
Right, so let's take it in that order. Rebecca, as I still know you, Sam, and then actually I mustn't be nasty. I'm not calling you Samantha, and I'm not calling him Christopher. So Becky, Sam, and Becky.
Thank you. Just to say that, so I'm the South East Essex Alliance Director, which obviously covers Southend, Castle Point and Rochford. So I'd really like to link in with you, Emily, and we can touch base after that.
Thank you, Becky. Sam?
Yeah, just another offer. We've done a body of work on this. We're doing some work with the university and Reza around coastal communities and Coast Gem, which we will link in with you, and be great to tag in with Becky. We have got a body of knowledge from our young mental health ambassadors in Clacton, Jaywick particularly. We would love to do some work on Canvey Island because we think there's some parallels and some shared learning that could go across those two patches. So it'd be great to work with you.
And Sam, I congratulate you on getting in ahead of Ian Davison with first mention of Jaywick. So
Working on it.
Chris Martin.
Yes, so I recognise those points particularly that Sam has made around deprivation and.
I'm struggling to hear you, sorry.
Sorry, I'm on the back, sorry, John. Yes, so I recognise Sam's points around those two areas in particular, Jaywick and Canvey Island. We've done some work and we are continuing to do some work, particularly in Canvey. So we'll be happy to join up around that. In terms of interventions, I think it's an interesting term, and my experience would be to start with those young people in those places. It's a personal thing. I would be concerned about if we have a box of interventions, and I know this is probably not what you mean, but if we kind of pick an intervention out of a box and say we're going to choose in that place, I would want to start with the young people first, because I think, and we'll come to it at a later item, which is connected in many ways. If we start with the young people, their real-time experiences in those places, it quite often, in my experience, surfaces some very kind of disruptive insights that are really helpful in terms of framing what we do next to support and help.
Very interesting, Chris. Thank you. Other points? Any other hands, Bill?
Oh yes, Matthew Sweeting.
Matthew, anybody on screen?
No.
Matthew?
Hi, thanks so much for the paper. I read your kind of research paper at the end, which was interesting. I guess my point's probably similar in really understanding real world research, in the sense of we know a lot of the issues. I come from a background of geriatric medicine and older person medicine with Chris Whitty, as you referenced. What I suppose, what intervention, I take the point before, but we do need to know what interventions work. I know they're situation dependent. And so research used in that area, actually, what 2 or 3 things do we know work and can improve, particularly with the ageing population as well in those communities where we need to reshape how we do health and care in that zone away from big urban centres as well. So I guess real world research as opposed just to theoretical as well. So which I think HDRC, the grant that we've got here, will start to pick up some of those questions.
Thank you. Thanks, Matthew. Do you want to respond to the points, Emily?
I think they're all fantastic points, and I would very much like to follow up with you to keep about them as well after the meeting. I just wanted to follow up. Was there any comments about data and maybe ICB data on young people's mental health at a local level?
I don't think there's any queries on it, really. I don't think so. I think in many ways you might want to pick it up with some of the experts, with Peter and Stephen. So it's just, there are many drivers, are there not, of the state of mental health. We were hearing earlier about the COVID impacts and so on. So I don't think anybody would dispute the data. I think the question that Matthew and Chris focuses are making, how do you then focus on where you you research how to get the greatest impact on the rest.
But I think I also want to set it up so that we've got a before and after of data to be able to check whether those interventions work or not.
I think you have an open invitation to talk to various people in this room who have spoken, to go and explore in a focused way with Rebecca, with Sam and Chris and so on. See how you can take it forward. I don't want to sound in any way anything other than supportive. I'm totally supportive. It's sometimes to understand, are the mental health issues in areas of deprivation in coastal communities different from what you would find in areas of deprivation elsewhere?
So that's what we were saying. They were saying there's some kind of excess mental health effect in coastal deprived areas versus inland deprived areas. There seems to be something extra about being on the coast rather than a deprivation effect.
So the research work I was involved with, albeit a long time ago, identified that one of the issues is that they saw their friends of ambition leaving, and there was a feeling of being left behind.
Yes.
that the quality of professionals, I had this in the Church of England, but also in the research we did, it is harder to get the best medics, priests and other professional community people, if you like, into the coastal communities. Often because of family reasons, that the partner, the spouse, wishes to have a career of their own and is less able to do it. So I can help you with a lot of this, you know. So
I think there's a lot of really good theories. Now it's time to test them.
it's again getting the clarity to enable the focus of which interventions in a world where intervention demand will far exceed the capacity for intervention is to see where, but that's the whole point of setting you up. So we'll look forward to learning from you. Okay, you've got many offers of help. We're all here to support you. And we wish you best wishes. And if you want to come back to this board in the future, do come back, Emily. Thank you. Thank you. I think that takes us to the Mid and South Essex stewardship piece.
Yes,
It's
indeed.
Matthew Sweeting, isn't it?
Yes, that's one. Hello. Hi, everyone. I'm Matt Sweeting. I'm the medical director at the Mid and South Essex ICB and a geriatrician down the road at Broomfield Hospital as well. I want to introduce you, assuming you've read quite a lot of the literature that we've provided for you, introduce you to the concept of stewardship, that we're all stewards of our resource. And I'll just give you three quick pointers before I take questions. The first is stewardship itself. It's based essentially, we are stewards. It's based on someone called Eleanor Ostrom's work, who's a political scientist and an economist. And I quote her words here, which I think are quite profound, but also has shifted the way we do leadership within our system. There is no reason to believe that bureaucrats and politicians, no matter how well-meaning, are better at solving problems than the people in the middle of it who have the strongest incentive to get the solution right. So it's essentially, the theory is based on something called historic commons, that we have a common, we have a shared resource to manage. We do not centralize it, but rather we give it out to our communities and to our local leaders who know best, our experts. And then you adopt a culture of stewardship. So you may want the shepherding analogy or the stewards. Now we've taken that approach in Mid-Essex to get a group of clinical and operational leaders trained in this methodology to deliver value-based healthcare. That essentially means you pool the resource, you have the total budget, not just money, but people and time as well, very much an economic model. And then you look at your system outcomes, not just provider outcomes as well. So it's a shared resource managed by a group of experts across no boundaries, across, in a sense, across health and care. And then you see, can we do something different with this resource and can we provide best value outcome? So that is the concept of stewardship, and that's what we're promoting amongst our leaders. Something it very much feeds into the heart of what we call in the business left shift, which is essentially, you all know, moving from reactive to proactive care, from illness to prevention, from acute to community and primary care, and from provider focus to a system approach. But that is very much backed up by data sets that look across the system outcomes of health and care, not just provider-based outcomes as well. And that is the absolute key here. And finally, I do think it's quite radical. It's been done before, and it's been done in other communities. But the idea being that you give, and it can be quite brave, it can be quite radical. We've not done it here in Mid-Essex to the whole fullness of it yet. But I just highlight those pages, and I'm not going to brief them now, but if you look at the achievements of our stewards to date between pages 161 to 171, one example being our Aging Well stewards. We've got a total budget about 360 million that we spend on Aging Well services, probably across our system. They developed a tool to really think about how we personalise care for older people, where we think about particularly the last 2 years of life and how we prevent unnecessary hospital admissions as well, all based on system outputs. So we are all stewards, and I challenge that the whole principle of us is we should steward our resource. This is a big focus towards moving towards less shift. And I think it's pretty radical. I think the next step for us as a system is to really put finance and contracts and some money behind this to push this forward in our system. So I'm more than happy to take questions. There's a lot of information in the papers.
Thank you, Matthew. It's very interesting, actually. Do I have some hands up and some real challenges for us in what Matthew's saying at a strategic level? I was hoping to hear from my colleagues from the other integrated care systems, Mr. Professor.
Has Susanna Howard's got a hand up?
Ah, Susanna. Welcome.
Good morning.
About your,
Say that we're doing some very similar work, which we've kind of moved on from left shift to future shift, which is about kind of, how do we get the system moving around delivering that left shift. So Matthew, it'd be really good to connect up on that, because the more that we can kind of join forces on how do you do this, how do you make this a reality in integrated care systems, the better.
Yeah, absolutely. I was when you started speaking, son, I was trying to sympathise with you about your injury. We hope you're off crutches soon. Anyone knows that Susanna will know that crutches won't slow her down anyway. So, anyway, any comments from Hearts and West, Ian, or if Paul's on the screen?
I will certainly relay it back to colleagues in our ICB, ICS, yeah.
I'm Jyoti, this is very much in your area. Peter, yours in adult social care, what was just being said about ageing well and the other elements of the stewardship paper? Jyoti?
Absolutely, it's absolutely what I would advocate, and it's music to my ears to hear people actually putting some energy into it, and really happy to work with you on it.
But the future shift is certainly the left shift, future shift work in SNE has been going on at great pace, actually. Peter?
Yes, I would echo Jyoti's sentiments, I think, absolutely. So I think we need to press forward and continue with it.
I'm feeling slightly, did this paper go out late?
No.
I was expecting a forest of hands coming up for this. I'm assuming, Matthew, that the relevant placidity of the board is just a statement of understanding and good wishes. But I certainly think there'd be a great piece to involve people from the MSE's partners, system partners in your conversations would be great.
Thank you.
Whether that's done by ICS or just from people like Jyoti and so on who sit across the whole team.
Thank you, and always happy. It's been made powerful to hear it from the stewards themselves. They have the passion, the drive, and they know the detail far better than I do. And I think that's the joy of my job, is to listen to them and their opinions.
The board earlier this morning benefited from passion in Tracy. If you want to bring, when the agenda permits, if you can agree with the office team, a couple of long just to speak to their piece, I'm sure it would be a valuable intervention.
Chair, may I just interject that
sorry, who's that?
It's Sam Glover.
Hi Sam, sorry.
That's all right. Just to say that during some of the early iterations of the stewardship, we were involved, and actually it's so important and so valuable and such a breath of fresh air, both in Mid and South and in Suffolk and North East Essex, that the voluntary and community sectors are included in those stewardship programmes as an equal and valued partner.
That's the third reference to breaths of fresh air we've had this morning, Sam.
Well, it's a lovely day out and I've been skipping around Chelmsford, so I'm full of it.
It's all in aid of Jyoti's air quality strategy. Ian Tompkins has burst into life. Ian.
I think you were Sam, looking at me.
Yes, sorry, I was just trying to attract Will's attention.
It was sort of semaphore or something. Anybody else? Matthew, thank you for bringing the paper, and thank you, Mike Thorne. I think you're on screen for suggesting it. You are hearing a tide of willingness to walk alongside and get involved. Okay.
Thank you very much. I think we look forward to working or sharing knowledge and understanding.
Thank you. We're next coming to the next item, which you'll be interested in, Matthew. I think the long-term longitudinal study on parents. I have been persuaded, and against my normal instinct, there is an 11-minute video which we will be enriched by seeing in totality. I've been told to keep speaking while they deal with the technical bit of getting it linked up, so that is it. But it's quite long, but I am assured that the discussion will be better in the light of it. Unfortunately, we seem to be up to date on the agenda, so you'll need to tell me when the video is ready to go, please, Jasmine.
Oh, yeah, I'm going to speak for everybody, so that's fine. We've got Chris, Martin and Katrina Glover.
So Chris and Katrina are now totally ignoring what they told me earlier, because the video would come first and they speak afterwards. Chris and Katrina, good morning.
Cross wires, Chair. I'm sorry about that. I'll be very quick. Just by a quick introduction, as colleagues around the room may know, in the past, Links to Essex Child and Family Wellbeing Service, we have some ethnography, some families who were just about coping, and we wanted to go back and see how those sorts of families were faring post-COVID and cost of living crisis. So ostensibly, this research is linked to our broader early help offer and how we can adjust our practice and respond to the kind of real-time experiences of families. Connected to the theme of the board, you'll also see a housing link, and you'll note the accommodation and living conditions that are a contributing factor to some of the challenges that are being faced by some of these families. And we often find that the simplest things have the greatest impact. So for me, you will see the 3 families within the film, some friendships, some meaningful work and employment, some improved living conditions will have a massive impact on their lives and the quality of their lives, of their families as well. Katarina's got a quick note around the research.
Yeah, we just tell us much more about it. We won't need to watch the video, mate. So
Just so that you know, the research was conducted by an external company called Revealing Reality. It is based on ethnographic research with 15 families across Essex. And in the video, you will see examples of 3 of those families and those everyday realities, which point to a lot of the things that can improve their well-being overall to them and their families and the school readiness of children.
That's it, yeah.
That's it. Yes. Thanks. Thank you to the board members for letting us show that film. I think just to wrap up, I've seen that several times now, and the messages are they're subtle, but they're quite powerful. There's something about the consistent use of social media and a searching for consistent and online advice that is with confidence. I really like the point that the mum makes about things for the kids to do. Really kind of simple stuff. She's not really asking for kind of complex stuff at all. It's just a general thing about, there's not enough stuff for the kids to do. And I think we've touched upon that in this forum and in the Children and Young People's Partnership Board around not everything needs to be new and innovative and spangly. Actually, there's lots of good stuff that's out there already. Might just need to do a bit more of it. Made the point about better living conditions in the kind of broadest sense. I think Mum's insights around there's no comfort with surviving, no one's happy, as it refers to a home, not a kind of property, not a house. I think that stuff's very powerful for me. And again, the usual pointers that we often find when we speak to families, such as those who are kind enough to share with us their lives, that point about friendships, but also the point of the value of kind of peer networks, about learning, about finding information, and actually those networks of support are often the most kind of reliable sources of information and support.
And I'm assuming you'll be taking this to the Caring Commission when they start meeting.
Absolutely.
Community care. Any points for Chris?
Carlo and Ian Dates.
Sorry?
Councillor Ian Dates.
Right, Carlo, yes, okay. And Ian Davidson, okay.
John, thank you very much, and Chris, thank you for showing us that video. I found this is something the committee I'm vice chair of. I've slightly touched in the past that maybe education should be the key to stop this kind of situation taking place. And I wonder if it's been raised many times before whether the curriculum for secondary school should include development for future life of parenthood, because that's really
the key to it all, if people realise before they go ahead and have families, what being a parent is like, before it's too late, maybe that will be something that, and I will take it back to my committee, but bearing in mind we've not got many months left, but I think that's something that would be very useful to do.
Ian?
Thanks, and Chris, thanks very much indeed. Really, it's how do we engage? Because a lot of the conversation there about people not knowing what's available, opportunity and aspiration. It's not necessarily about professionals being able to do that. It is about what the leisure club's going to be over the holidays for children, or and how do you raise aspirations? It's a comment really, but more around us thinking about how we tie in our localities to that, and how we do that, and kind of going away saying, oh yes, that's what we should do, but actually I almost don't want to leave it just as a comment of the bleeding obvious, if you like, when it's how do we integrate that. And I'm thinking, a couple of those examples were in my area, so I'm being slightly parochial, but it is linking up to that aspiration and that opportunity to in that work. And I don't know if we're all plugged in well enough to do that. And I think
I agree. How do we listen to those families and galvanise what we have collectively at a place level in response to the kind of relatively straightforward things that they're sharing with us?
Are you having this parallel conversation at the local health and wellbeing boards? Because that's where you'll get the local partners coming in.
And I was just noting in that we're coming on to the Alliance reports, which very much are the locality areas, not at district level, but at Alliance level. But equally, how you tie in some ways, the district, borough council, city councils have almost more to do with the creation of the maintenance of the living conditions in a way more than the county councils, as you well know. I just did think you were saying about raising aspirations. Some of it for me is avoiding the suppression of aspiration. Surely a lot of these people that we've seen there would have come into adulthood with high aspirations of where things were going. We heard from the primary school teacher, a very worthy job, and so it's just, things get beaten down, don't they?
If I may, John, just so we had one example not very long ago where the parents were actually purposefully suppressing the child's aspiration of what the child wanted to do because they didn't want the child to be better than them.
Well, we could get into a whole debate about that. I'll look at the work we did on recruitment to the selective schools, where they reached out, the Chelmsford ones reached out to try to get a more inclusive attendance or inclusive engagement, getting more young people from deprived areas to set the 11 plus to get in. And actually, it was the parents saying that they didn't think the children would fit there, so they didn't put it forward. No, we had some more hands up, you said, Will?
Yes, we do indeed. We have, I'm so sorry, I can't recognise you from here.
You don't recognise me, I'm Zoe Oddie from HCRG Care Group.
All right, from HCRG Group. Maybe that. And
I didn't catch your name, I'm sorry.
Zoe Oddie.
No. So if you go first, who's after that, Will?
We've got Paul Burstow online and Ian Tompkins very much in the room.
Okay, so you fire away then, Paul, then Ian.
I was struck by the stark difference in the health visiting provision in Colchester and in Harlow. I just wondered whether we'd done any more investigations into whether that was standard provision in the Harlow district or whether that was just one health visitor.
I think I made a comment about provision. I think I made a comment about the experience.
Yeah, okay, about the experience.
Yeah. It's just literally a piece of research learning from those families and had contact points with health visitors. They shared with us what that experience was like. Which I guess is a reflection of, you'll always get a degree of variation when
you do.
There's more detail available in the full report, which we are happy to share with attendees. So you can delve into a bit more detail, but otherwise it was taken at face value. Things were not delved deeper into.
Okay, thank you.
It is quite a big report, so I think Clyde suggests those of you who want it, just let the Secretariat know. Paul Burstow, then Ian Tompkins.
Yes, thank you very much, John, and thank you very much for that really interesting presentation. I can't help but feel, and the slides ask the question, how did the video make you feel? And I think the way it certainly made me feel was frustrated, because many of the issues that were described there could have been in a video shot 10 years ago, or in a video shot 15 or 20 years ago. The real question is, how do we make sure that they're not in the video in 10 years' time? And I think this is not, this is a classic example of where many agencies are doing many good things, but the day-to-day pressures on people's lives are just sort of acting as barriers to people actually having the opportunity to access those services. So I just wanted to pick up on the fact that at the next Hertfordshire West Essex Integrated Care Board, we have a deep dive on children's services, and that can become quite a service-orientated discussion. So I just wanted to sort of say it'd be good to look to see how we can make sure in that deep dive some of the insight from this video, even if we don't play the video, to be honest, could be brought in. So I'll just mention that to Chris. It's really very powerful.
Thank you, Paul. Ian Tompkins.
Yeah, just briefly about that lack of awareness between organisations of what is out there. There is a heck of a lot out there. Equally, the social media space and other routes for publicising stuff is as crowded as a Heathrow airspace. There's too much. People can't understand it. And in Harlow in particular, we've started to think, I do it myself even, I think it's worthwhile once a fortnight, 2 hours investment in time to produce Harlow Connected, and it's about joining the stuff up. I was yesterday with our Bounty Club, our food bank and community hub partners. These are the touch points that people like those in that programme form trusted relationships with. And it's so important that we put everybody in that network on message about what is it, so that they can then engage with people and encourage them through those relationships to take stuff up. And we're doing a lot of work with the Children and Family Wellbeing Services and others in schools and early years settings in Harlow at the moment to that effect. And it's really starting, I hope, to have an impact.
Absolutely. Thank you, Ian. Any other before I bring Chris back in?
Yes, Pam, great.
Hello.
Hi, thank you. I think we just have to be a little bit careful sometimes with the videos. They're very emotive, but I think we need to think about the stereotypes that we're reinforcing sometimes with the content. And whilst it challenges us here, are we playing into the rhetoric in the right way? We need to think about the positive role model. And actually, I look at those mums and think, aren't they phenomenal?
Thank you.
Because actually they're managing a huge amount. And what the report might tell me, but what's behind that situation? Actually, we have to create some real championing of those women leading those families under extreme circumstances. And we know that these are the women, because of those circumstances, that don't take up things like cervical screening because they have no network around them. And I just want us to challenge ourselves about, is it the right thing to do to propagate some of the video content that we have all the time, or can we think about a more positive angle on it sometime? I said I was going to be provocative, John, but we really should challenge ourselves.
It is absolutely fair challenge. Okay?
That's how it made me feel. That it was about the female role. So there was quite a heavy bias on that.
Yes, single mum.
I guess it's from your perspective, isn't it? But I'm with you. I see those mums, those women as incredibly strong given their set of circumstances. I guess it's
let's tell that story as well, so that we've got the flip side, I think.
Yeah, it does, but your perspective, yeah. Sorry.
It's a fair piece that if one of the case studies was a couple of whatever nature, and they are as equally time poor and pressurised, if you see what I mean. It just broadens the debate. Did you want to respond on any of the other points from Paul or Ian?
I would just add that, again, in the report, you can read about the other families. There were couples, there were grandparents looking after children. So a broader range of families. These were the only ones that were like happy to actually be on camera, but the others have shared more.
Thank you. We are coming on to localities in the form of the Alliance report, so if there's no other points for the Chris. Thank you both. Good educated piece, and it was my request that you came here, so thank you.
Thank you very much.
We come on to the Alliance reports. I want to pick this up alongside, you are due an update on how we're taking forward the health and wellbeing strategy work, Jyoti and Ian, so I'll come to you after the Alliances. Can we do a sweep through the county? Shall we start in the west? Is that you, Ian?
It is. Thank you, Chair. Bit of breaking news to start with. It's been announced today, I believe. Tom Lafferty is to become the new Chief Executive of Princess Alexandra Hospital. Tom comes from Southwest London, a couple of trusts there, and he is replacing, of course, Lance McCarthy, who leaves the hospital to go to Frimley at the end of this month. So that's just hot off the press, as I say. Just a few items to pick up of note, perhaps. We've also got the West Essex Health and Care Partnership, a heart failure workshop taking place in July to develop an integrated heart failure model. Personally speaking, I think that's really important, having had 2 heart attacks. Going through the heart failure clinics, and how we can take on that lived experience from people, I think is really important. So we've also won a national bid to expand hypertension case finding in dental and optometrist settings. That goes live in September 24. Our integrated neighbourhood teams are progressing well. I think obviously principally in the first stages from a health and care point of view, but I'm personally keen, and I know a number of our partners are, to widen that out into those all important wider determinants of health area, so that we genuinely do join up our services in localities as well. We are also in conjunction with ePut and Public Health and others doing some work in, Davidson mentioned it earlier, around suicide prevention. We're looking together with the police, Essex Police, Railway Police and others in West Essex to develop a distress pathway, as we're calling it, to improve wraparound prevention and care, recognising that mental health is just one contributing factor to self-harm and suicides. I've already hinted at some of the great work we're doing in Harlow principally, but we are looking to roll it out across wider West in relation to schools, and we have all of the head teachers in Harlow engaged with us, health leaders, and also skills and employment colleagues from here at Essex County Council and Public Health. We're looking at, particularly at the moment, around children's level of development, GLD, healthy weight, oral health, that links directly into the work that we've had in front of us here, and around mental health as well. The child's good level of development by the age of 5, GLD, as I mentioned, is a key contributor to their health and wellbeing in later life. We're focusing our initial activity on parenting skills as basic as nappy, potty training rather, and school readiness throughout what we call the bump to 5 period first. We'll then work on later life as we go along. And then also just to say that there's quite a lot of work that we're about to launch in West Essex around planning growth and creating healthy places. The Chief Executive of Harlow District Council came to us from Oxfordshire, where there has been quite a lot of work done there around Bicester and Banbury, and we're linking up with them to find out their experience. And obviously we will be looking to share that with colleagues here today in due course. And also just announced, because of the pre-election period, that Harlow and the West Essex Health and Care Partnership is now part of the extension of the Sport England Actives Place Partnership work. And the Harlow has been awarded, all of us, a £80,000 grant to develop a bid for what will eventually become hopefully a delivery programme from April 2025. That's probably it for me.
That's great news, well done. And lots of good stuff in there. I think the Healthy Places piece, Tom Walker, would be very interesting to have as an agenda item or even a workshop at some point. Thank you. So I'll come down, let's go to South West next. Is that you, Pam?
Yes, it is. Yes, thanks, John. There'll be similar themes, obviously, as we're placemakers as a profession now, I think. Really pleased to say that 4 out of 6 of our integrated neighbourhood teams are now up and running in Basildon and Brentwood, and that was coming from quite a slow start. And one of them is particularly focused on frailty. And is freeing up a large number of on-the-day appointments, and it's great to see that our social workers, our community matrons are locating with general practice and triaging the morning and distributing the work together. And whilst that started as just a co-location, actually what it's doing is creating greater connection between the teams to work together rather than having a referral-based model, which was what we were really aiming for in the design of these integrated neighbourhood teams. And it's increasing everybody's confidence. So, you know, if there's a safeguarding issue that's known about by social care, it doesn't initiate another one if people are worried. There's a conversation. And there's some really good messages coming out from that. In working that way, they've been able to reserve across the PCN 100 on-the-day appointments to prioritise frailty, things that we didn't think would be able to happen quickly. And that's meaning that those individuals that need the best care quickly are getting it without having to compete through other systems. So real focus on frailty and urgent sort of response at practice level. On the back of the work that the stewards have done under Matt's leadership and Roland before that, we're looking at rolling out the frailty tool Frida, which we've talked about in this group before, to really get as much stratification of our population so all those INTs can be working with the most impactful groups ahead of winter. So we're able now to get more of a consistent adoption of some of those tools. We've taken a real focus on housing following the work that has been presented from North East here before, working with Basildon Council because of the waiting list issue. So housing officers are part of those teams as well, and that's really supporting the practices where accommodation is presenting recurrent issues. We're also looking at rolling out something called the Black Talent Charter, so looking at equity, racial positivity within our workforce, working with NELFT on that. I think it's an important aspect of maintaining our workforce and valuing all of our workforce. So it's something I'm really, really focused on. So they're the main highlights since we last met anyway.
Very interesting. I will take any questions at the end of the report. South East, Becky.
Thank you, Chair. Yeah, great to be here. So 5 months into the role, the priority for me has been to work with my system and partners to be really clear about what it is we are going to focus on and deliver. So we've developed our delivery plan in South East and reset our governance to really accelerate that. And we have organised ourselves around a single outcome, which is healthy neighbourhoods, with a targeted focus on healthy start, healthy living, healthy minds and healthy ageing. I think it's really important to say that we've done this through the lens of the place-based partnerships being a vehicle for delivery as an ICB, but also supporting our financial recovery. Like Pam and Ian, we continue to develop our integrated neighbourhood teams. 6 of 8 are actively working in a multi-agency way, and particularly in MSE, we are working towards a common outcomes framework to be able to really
build, develop and be able to quantify what those integrated neighbourhood teams are achieving and contributing towards that left stroke future shift. One of the real focuses in Castle Point has been the expansion of the place expansion programme with Sport England, particularly Canvey Island has been chosen as one of the kind of new additional areas. So really learning from the work that's already happened across Essex. The first scoping phase has been approved. So we're working actively with Active Essex and partners in Canvey to really develop and plan what we could do differently to improve physical activity and wellbeing. And if I may, John, I think it's really bearing in mind the previous item. Actually, what came through in that initial discovery was, particularly in an area like Canvey Island, that there is actually a lot of opportunities there, but families and children are not choosing to engage in those opportunities. So I suppose I'm saying that because it really draws to the point about how we need to use our localities to engage with local people to understand what it is we need to do differently. And then I'll just finish to say, and as part of that, we continue to really work around our CBD performance. Circulatory conditions are some of the highest impacts to early attributable to social inequality. So we're doing huge amounts with our primary care, pharmacies and healthy behavioural service to improve that position.
Okay, these are very helpful reports. We're going to run 5 minutes over if people don't mind. Thank you. Jyoti, I've heard about Harlow, I've heard about Canvey Island. There must be a full announcement about where else in Essex has been included in the Sports Signal programme.
You know, it's also one of the other areas, John.
Right.
Thurrock is one of the other areas.
Perhaps we can have a full briefing, please, because this is all news to me. Right, I'm not shooting the messenger, by the way. What I would observe is I would also hope the place-based working would take account of the county health and wellbeing strategy, which I see you as the key drive engine for at Alliance level. But Ian will give and Jyoti will give us very short updates in a minute. But Dan, you're next for mid, and then I'm going up to north.
Yeah, and I won't repeat what others have said. Big focus on the integrated neighbourhood teams in mid now. All 6 are functioning, but it's fair to say there's a spectrum of maturity in terms of where they are. A better focus now around the interface with Mid and South Essex hospitals, in my case, particularly Broomfield. Some people here heard from Matthew Hopkins yesterday about the new structure in the hospital. That should allow those integrated neighbourhood teams to focus on that kind of admission avoidance over winter, which we've also heard about, and fits in with what Kate was saying about preventing ambulance call-outs. The only thing I suppose that's somewhat unique to Mid at the moment that I would add to what colleagues have already said is there's a big focus for us at the moment, particularly using the Chelmsford local plan as a sort of, I guess, a test case. We've got a significant amount of growth, as colleagues know, within Chelmsford. It's going to present significant infrastructure challenges for health to be able to address that. So we're looking at that through multiple lenses, particularly primary care, so in terms of GP provision for the new areas, but also starting to think about the impact that may have on larger organisations such as Broomfield Hospital, proximity to A&E being a key predictor of A&E attendance, but also impact on the ambulance trust as well. So a number of focused workshops in Mid-Essex, particularly around that Chelmsford area and how we're going to address the kind of significant housing growth that we're seeing. That's not to say it's unique to Chelmsford. Obviously, other areas have that growth as well, but it's very present and here and now in Chelmsford. And so as an ICB, we're going to learn from that so that the other alliance areas can take some of that learning and move it on. But beyond that, John, I think colleagues have covered a lot of what I would have said.
I think what's special about Chelmsford is particularly chunky. You've got lots of 3,000 and 4,000 housing developments to think of, and not just primary care in the traditional sense, Dan. Primary care in the progressive sense.
Exactly that. Exactly.
We knew we already have a facility in Bewley that's too small, but we won't go there. Who's speaking for North? Come forward. It's quite hard to.
Around the table, I'll shout louder. Just an update in a similar way to other colleagues, we're in the process of really embedding the new governance structure that we've undergone a review of over the last year. So we now have an Alliance Operations and Commissioning Group that oversees all the delegated responsibilities from the ICB board. We have our Alliance Place group, and I'm really grateful to colleagues, especially those in Tom Walker's team who've really engaged in that. So we now have a planning and place group, a housing and place group, and we're also looking at skills, employment and training and thinking about other elements such as educational attainment, and we've got really good engagement in that. And then to your point, Councillor Spence, around how we're supporting the Essex Health and Wellbeing Strategy, we're also now going to start a healthy behaviours group, which will ensure that we're meeting the objectives, not just in that strategy, but also the public health business plan as well. And that also enables us to have an ability to support the deepening work in the Sports England local delivery pilot. So that group will also be up and running. I'd also like to note that colleagues with the Better Care Fund, that work's really progressing well. We have a real ability to see future problems around winter discharge. And we're also making sure that we're aligning to the objectives in that national policy around mental health and learning disabilities going forward. So I'm grateful for colleagues in that space. The real focus for us, though, is now around integration. So working closely both with Tendring District Council, Essex County Council and Colchester City Council, really understanding about what our people in North East Essex need from us as a collective group of statutory services. So we're having a workshop in early September to really think about integration and what it means. Ensuring that work takes on some of the reports that Healthwatch Essex has done previously, not just in North but in other areas, and also future policy, not just from the joint forward plan that we already have and has been signed off by this board, but also other strategies and refreshes that are coming down. So that's just a very brief update from North. Thank you.
Thank you very much. That was very helpful. Thank you. That takes us around. That's all very useful. Now, you referred to the wellbeing strategy. So, Ian or Jyoti, do you want to give us a word on next steps and that? And I'll say a word about integration.
Hey, John, I'm very happy to give you a very brief update on that one. So the board remember that we discussed that the 4-year strategy for the health and wellbeing strategy, we're 2 years into it. We're going to have a review of what we have done so far, and then have a look at what do we want to make what are our priorities going to be for the following 2 years. We had arranged a workshop for late in June. Unfortunately, somebody decided to call an election, and also availability. So we've now made it for the 1st of August at 10 o'clock. It will be online, and it is about that, looking at that opportunity to say, is what do we want to go forward. I think actually, in one respect, the timing is helpful because obviously we're hearing a lot of announcements coming out of government. And I think actually just give us some moments to reflect on what they are and how we will, as for the next 2 years of the health and wellbeing strategy, how we reflect on that. I think it's also a very useful timing in terms of what seeing at the moment is that there is a cusp around where potential funding could be. So as well as policy, as well as the funding. So do we need to reflect that? Or our health and wellbeing strategy cover that? I'll just say one other very quick thing is please, if you can, make sure that somebody can attend, either yourself or somebody senior. It is really important. It is really there because it is about setting it's not a health document. It's about a sector-based approach to our residents. And it's about supporting them in all sorts of different ways. If you read the strategy as it is now, it's much broader than that. So we want to just be able to make sure that it's relevant for the next 2 years, and it's achieving collectively what our aims are going forward.
Thank you. And could I ask you, please, not just rely on that verbal invitation. I suggest, Ian, that you get a note out to all our district and borough council partners as well who are not here. Okay.
John, thank you for that. Some have already gone out. There are some going out today, all the districts, and we've also raised that the chief executive and districts are going out. There is a briefing note which goes with it, which we are sending, will be sent depending on how.
On the integration theme, just the excellent work being achieved by the Alliances, well done to all of you. Behooves a proper response from Essex County Council. Rather than take up time, I will just inform you that the Integration Board has been reinstituted here to make sure that our various functions, public health, children, adult education, all speak into theirs with common voice and shared understanding, so that you don't get different people for the County Council giving different messages in different places. Is that a fair way to summarize?
Yes,
And I just, reference was made by Dan to a meeting yesterday, just to advise you, there was a meeting yesterday with the Mid and South Essex Hospital Trust and the appropriate scrutiny committee, the Health and Oversight Scrutiny Committee, where a very good conversation was held, and where again, I think that it's fair to say the opportunities for integrated and cooperative working just stood out for us, didn't they? So, I'll just observe that.
If I may, I'd be very remiss in not thanking Shami, Nathan, Kate and all the team around the support they give for this work, because it's hugely important, and obviously to Jyoti and her team.
And I would have been very remiss in not giving you 5 seconds to say thank you. I've been asked to allow now, really need you to keep this down. Who's doing it?
It's Claire Hardy.
Well, you have, all board members have received an update on it. You see assurance visit to the whole of Essex County Council, but they will come and talk to other partners very, very briefly. Well over, Claire.
Okay, no worries. So hopefully you're all aware of CQC, the Care Quality Commission. As of the Care Act, Health and Care Act 2022, they gained a new responsibility to quality assure each local authority. They've commenced that process and they hope to complete every local authority by the end of 2025. As Councillor Spence just mentioned, we received our notification on the 20th of May. The first part required us to make an information return where we submitted a self-assessment and key evidence and data. That has all gone in. CQC are now reviewing all of that information and will start reaching out to some of our partners. And in particular, they'll be contacting providers with a survey and voluntary sector partners. They may also be asking some of the voluntary sector partners to help them organising focus groups with adults with lived experience. CQC will be looking at 4 key themes. The first one is how we work with people, which includes how we assess people, assess their needs, but also how we do early help and prevention. The second theme is how we provide support, so how we work with the market to ensure a good supply of quality provision, but also how we work with partners and our communities. The third is around ensuring safety, which is not only safeguarding, but also how well people move safely through the system. And the last is leadership, which is decision-making and culture of continuous learning. So just in terms of what happens next, CQC will confirm a second date for an on-site visit. We'll have 6 to 8 weeks notice of that. When they do, we'll need to pull together a timetable with a series of interviews and focus groups. So we will be reaching out to you as our partners because they'll want to meet with a number of you, either as part of an interview or as part of a focus group. They'll also be meeting again, as I said, with adults with lived experience, carers and members of our workforce. They will also undertake some case file tracking, so they may also need to engage with some of your organisations in relation to that. So, yeah, really just to let you know that this is happening. We don't know when that second part will take place. We're just thanking you for your support so far. If you need any help with any of the requests or not sure on anything, we've got information prepared, please give us a shout. We're sending out through all of the alliances, and we'll send out to the board as well a summary of the self-assessment so that partners can access that and have a look at that as well.
Thank you. And we are told to get 6 to 8 weeks notice. Suffolk and Hertfordshire have been through this already. As you'll understand, the model here, because we're Essex, we're bigger and more complicated than anybody else. We've always gone about that, don't we? But Claire, thanks to you and the team for the massive amount of work. I mean, others will know as well as I just how many documents are involved. So thank you. We're on to any other business. I've not been notified any. The date of the next meeting is Wednesday, the 18th of September, if I think correctly. And I think we're aiming to have a workshop around primary care and community and how we can all work together to minimise the strains on the hospitals. Nathan, we move